So this has been in the pipeline for quite some time, and I thought maybe I should just release this video on cervical cancer because I've been getting so many requests to do this. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at cervical cancer. So if you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper and your pen and let's go. So in the vein of the new style of the lectures that I'm going to be giving, we usually start off with the warm-up question. So this is a true or false question. With regard to cervical cancer is the third most common cancer in women worldwide. Part B, the incidence of cervical cancer has become far more common in young women since 1980s. C, the death rates from cervical cancer has remained steady in recent years. D, human papillomaviruses type 14 and 18 are the most commonly associated with cervical cancer. Then cervical cancer is associated with previous infection with herpes simplex virus. So keep these questions in mind. You may answer them right now, but I will definitely give you the proposed answers at the end of the lecture. So please stay tuned and stick till the end of the video. So now, just before we dive into going into details of cervical cancer, I just want to give you some anatomical perspective. Okay, so remember that the cervix is pretty much the neck of the uterus. Now, the cervix can be divided largely into two parts. It can be divided into an endocervix, which is pretty much the one that's shaded in brown here. So this originally has columnar epithelium. Then you have the ectocervix, which is the one that is outside shaded in blue. This is covered in squamous epithelium. This is, of course, non-keratinized stratified squamous epithelium. This is continuous with what you have in the vagina. So you have the endocervix and you have the ectocervix. Now, the junction where these meet, which is known as the squamo-columnar junction, is not really static. It tends to move, and it moves with certain places. It moves with puberty, it moves with pregnancy, it moves with menopause. Now, there are some changes that are supposed to be happening, because remember that these cells that are in the endocervix are continuously growing and eventually are going to differentiate, and the basal cells from the endocervix will eventually find themselves in the ectocervix, and they're supposed to actually undergo some form of metaplasia. So they are supposed to be converted from your columnar cells, and they are supposed to be replaced into the squamous cells that are found in the ectocervix. So this process is actually under the influence of certain hormones, one of the hormones actually being estrogen. Now, the change that is happening and resulting in the movement of this squamo-columnar junction is pretty much going to be changing the epithelial cells from being columnar to being squamous cells. Now, the zone of which you call this is referred to as the transformational zone. And I want you to remember this, the transformational zone. Why is this so? It's because this is the area where the cells are most susceptible to infection with human papillomavirus. So the bulk majority of the cancers are going to be arising from the transformational zone. Now, remember that when you have a lot of estrogen in the body and estrogen levels increase, the vaginal epithelium actually is going to accumulate glycogen, and then lactobacilli inside the vagina can actually work on this glycogen to create an acidic pH. So you find out that in adolescents, those that have just hit puberty, the transformation zone happens to be on the outside. It's rather exposed. Now, if this transformation zone is slightly on the outside in puberty and most of the reproductive years, you'll find out that during this period, if this person undergoes any early sexual activities, these cells can be infected with HPV and they put themselves at risk if there is a persistent infection. Take note, persistent infection of HPV, then it can predispose them to some cervical changes that are going to be leading to what is referred to as cervical dysplasia, or you can call it as a cervical intraepithelial neoplasm, which we will talk about, and then eventually progress to cervical cancer. So it just doesn't come out like boom, you have cervical cancer. Then of course, as you go into pregnancy and beyond pregnancy, especially during menopause, the transformation zone is actually found on the inside, so it's rather protected. So I hope this makes sense. Most cancers are going to be arising from your transformational zone. Now remember that cervical cancer is actually an invasive carcinoma that's going to be arising from the cervical epithelium. It is actually the third most common malignancy in the female genital tract. And the most commonly seen cancers are going to be seen in women that are aged 40 to 50. I'll explain why. The mean age of diagnosis is going to be roughly around 50 years, but we may see some changes of the cancer that may progress, and you may see them as early as 20 years. I'll explain also why. Because of the HPV infection, the persistent HPV infection. Now remember that cervical cancer is going to be as a result from cervical intraepithelial neoplasia, which is caused by many human papilloma viruses. But the important ones that I want you to know, 16 and 18 are by far the most common. We actually do vaccinate individuals against them. HPV viruses 31, 33, 35, 39, these are all known as high risk HPV. So if you get these viruses and they remain persistent in your body, they may cause some dysplastic changes and they may lead to cervical cancer. Then of course there are some secondary risk factors like smoking, immunodeficiency. This is because you're not able to clear out the virus. So if they do have some immunodeficiency, then you're not going to be able to clear out the virus, and this is going to be leading to some coilocytic changes in those cells of the cervix, and eventually it may progress to cervical cancer. Then of course it may be related to diethylstilbestrol exposure, which is pretty much a type of estrogen, or rather a type of steroid. Then of course this is exposing them to adenocarcinoma. Then of course the treatment is going to be dependent on the stage of the cervical cancer. Now what are some of the risk factors? Let's go into details. Remember I told you persistent HPV infection. In 80% of the cases we see that there is an HPV infection that precedes the changes that we are having in cervical cancer. There is an HPV infection that is implicated with cervical intraepithelial lesions. There is an HPV infection that is affected with cervical cancer. Now, what is HPV? Remember that human papilloma virus is actually a DNA virus. It's going to be transmitted sexually, so it's going to be through the infection that occurs from infected intact skin, mucous membranes, or even some bodily fluids from an infected partner. Now, the risk is greatest if the infection persists more than 6 months. Keep this in mind. That's why I kept on emphasizing that persistent HPV infection. If you get it just once and your body clears it out, if you're immunocompetent and your body clears it out, or you don't have any ulcerative sexually transmitted infections, then you're at a better chance of fighting off this HPV. Over 75 subtypes have been identified, but of these 75, the ones that are rather high risk factor for causing HPV include types 16, 18, 31, 33, 35, 39, 45, and even 56. Now, these are going to be leading to certain changes, which we call as a premalignant lesions. They cause dysplasia in the cervix. I'll explain to you how they do that very shortly, but for now, know the high risk types. 16, 18, 31, 33, 35, 39, 45, and 56. With the two most important in this group being 16 and 18. Those are the ones that are common. On the other end of the spectrum, you have the ones that are low risk. That's pretty much your 6, HPV 6 and 11. Now, these are going to be associated with benign condyloma acuminata, which are pretty much genital warts. You call them Condyloma acuminata. It's like they are accumulating on top of each other. So they kind of look like cauliflower. Do not confuse this with condyloma lata, which is seen in syphilis, and it obviously has a flat top. These ones usually have a bumpy top. Then other low risk types include 42 and 43. So when we actually vaccinate girls, adolescent girls, against HPV, those that haven't yet undergone any sexual activity, then we usually give them what is known as either a bivalent vaccine or a quadrivalent vaccine. So the quadrivalent vaccine is going to be consisting of HPV type 6, 11, 16 and 18. Then of course your bivalent will only have the 16 and 18 types. Now, what exactly happens if you get infected with these high risk types? So remember that HPV being a DNA virus pretty much means that it's going to integrate its genome into your host genome. So it's going to be infected. The infection is made much more prominent, or it's made much more effective if there is some ulceration to the mucosa of the genitourinary tract. So meaning that if someone has sexually transmitted diseases that are causing ulceration in that area, this is going to be predisposing an individual to getting this persistent HPV infection. If they have a poor immune system and they cannot really ward off or fight off this HPV, then there will be a persistent infection. So once the HPV now gets a hold of your host genome, it starts to code for proteins, because that's what viruses love to do. When they invade their nucleic acid in your nucleic acid, they'll start coding for their own protein. So they make two types of proteins: the early open reading frame proteins 4, 5, 6, and 7. I just want you to worry about 6 and 7. So the E just simply stands for early open reading frame. So you can call them as E4, E5, E6, and E7. Now these are usually expressed in the early life cycle of the HPV. Then they can also form other types of proteins, which are known as the late open reading frame proteins, that are pretty much 1 and 2. But I really want you to worry about E6 and E7. Why should you worry about these? Because these are the ones that are going to be causing changes to the cervical cells that are going to immortalize this cervical cell, render it unable to die by apoptosis. It won't be able to respond to any of the normal signals that tell the cell to die by apoptosis. And of course, this may also cause HPV-induced neoplastic transformation. So E6 is pretty much going to be increasing the destruction of p53 gene. Now remember that once this has been downregulated, remember that p53 pretty much regulates the growth of the cell. It regulates the cell cycle. So it's going to be regulating the G1 to the S phase in the cell cycle. And this is a very important step because it checks and repairs any DNA that has been damaged. And if it fails to repair this DNA, then it leads to signals that are going to cause this cell to die by apoptosis. Another tumor suppressor gene is known as your retinoblastoma, and E7 actually increases the destruction of this retinoblastoma. So you knock out the p53 and the retinoblastoma such that these cells become immortalized. They keep dividing regardless of them having some DNA mutations, and they now start to show some characteristic changes which end up them changing their characteristic morphology, and we refer to them as coilocytes. So these coilocytes have an enlarged cell which has of course a perinuclear halo, and then of course the nucleus is large, they are irregular, and they are hyperchromatic. I'll show you what they look like. And this is actually how they look like. So you get these coilocytic changes, which are usually the hallmark of HPV infection. So they're going to be large. They may be vacuolated squamous cells with a clear perinuclear halo. So you get these large cells, These are known as coilocytes. The nucleus is large. It's also hyperchromatic. As you can see, it's darker than usual. It's hyperchromatic, and they may have multiple nucleoli on the inside, and of course they're going to be irregular in size. Then of course these are like the coilocytic changes that we see in HPV infection. Now other risk factors include increase in sexual activity. This of course increases the chance of you getting the infection. So especially in those that are below the age of 17, remember the transformational zone is going to be on the outside. Multiple sexual partners also predispose you to getting the HPV. And remember that HPV in males is carried, especially in uncircumcised males that have poor hygiene. There can be some collection of dirt and all these other nasty things in the foreskin, which we call a smegma, which can sometimes breed an environment for carrying HPV. So this is how it can be transmitted from a male to a female. Then of course, you may have some sexually transmitted infections, especially those that cause ulceration. Early age at the first pregnancy, so too many frequent and too frequent births can cause HPV, rather predispose someone to cervical cancer. cigarette smoking, is there anything that cigarette smoking doesn't cause? Then surprising enough, actually, it decreases the risk of fibroids. But anyways, that's a topic for another day. Then you have age above the age of 30, immunosuppression, like I already said, or any cause of immunodeficiency. In our case, HIV is the most common cause of immunosuppression. Then you may also have low socioeconomic status, genetic predisposition, oral pill users, even husbands whose wives have died recently of cervical cancer. There was a president somewhere out there. This is a story of a president who married a wife. Then the wife died of cervical cancer. He married the second wife. Years later on, she started showing some changes, and eventually she also died of cervical cancer. He married the third wife and also started showing changes of cervical cancer. So the common ground between all three women was the husband. So the husband was a carrier of HPV. Now remember that regardless of the sexual history, the clinician, you who's facing the patient, you must always assume that a woman has been exposed to HPV, because HPV is ubiquitous. It is everywhere. Now remember that cervical cancer just doesn't come like that, boom. So first of all, there has to be some progress that happens. So your cells get infected with this HPV. They start to show these coilocytic changes. Eventually, these affect different layers of the cervix. So there are different grades that we have, what we call cervical intraepithelial lesions or cervical intraepithelial neoplasms, which we call the CIN. So you have three types of CIN. You have CIN1, CIN2, CIN3, and then eventually you're going to have what is known as a carcinoma in situ. Now, carcinoma in situ, when you see the word in situ, it means it hasn't yet crossed the basement membrane. Remember that all cells are going to be resting on a basement membrane. So as long as the basement membrane has not been crossed, then you just refer to that as a carcinoma in situ. If the basement membrane has been crossed, then you call that as invasive carcinoma. Then someone has a carcinoma of the cervix, or a CA cervix in short. So we'll talk about cervical intraepithelial neoplasia first before we actually dive into the features that we see when someone develops invasive carcinoma, so that you understand where we're coming from. So there's going to be some dysplastic changes that are going to be happening in the squamous epithelium, and they're going to be showing varying degrees of proliferative activity. Of course, there will be some cellular atypia. Now, this is the reason why we perform a Pap Smear, a Pap Smear, which is going to be done so that we can assess this dysplasia that we're seeing. We can assess and actually recommend that a patient may actually get a biopsy to actually see if they definitely do have cancer or they not, because science is an objective thing, so seeing is always believing. Now, 80% of the cases that show cervical dysplasia, most of the times we realize that it's actually due to HPV. So in all these cases, we actually do strive to test for DNA against HPV. So we do what is known as HPV Dna testing. These are just some of the screening methods that we will look at to screen out for these cervical intraepithelial neoplasms and also screen out for cervical cancer. So these cervical intraepithelial neoplasms are pretty much going to be the first changes that we see before invasive carcinoma. So you may find out that for it now to progress from CIN1 to CIN2 to CIN3, it takes a bit of some time. It takes a bit of some years. Which is why someone would have gotten the HPV infection years back, and then they tend to develop the cancer maybe like 20 years after that. And if they got it maybe at 17 or maybe even at 20 years, then they start to manifest with this invasive cancer after 40 years, which explains now the age of diagnosis, which is roughly around 50 years. I hope that makes sense now, and it makes some logical chronology to the order of the disease. Now, the cervical dysplasia and cervical cancer actually lie in a continuum. Like I said, it's not just, you don't just get boom, cervical cancer there and then. There should be a progress through the cervical intraepithelial neoplasms, 1, 2, 3, carcinoma in situ, and then eventually invasive carcinoma. Now, when you get a dysplasia, it can undergo three possible changes, so three pathways. When you get a cervical intraepithelial neoplasm, it can undergo three possible changes. So number one, it can progress to cancer. So you can have a CIN1 that progresses to CIN2, it progresses to CIN3, it progresses to CIS, which is carcinoma in situ, and then eventually progresses into invasive carcinoma. Or it may actually remain the same and not progress. So you can just have a CIN1 or 2 that just remains as a CIN1. But eventually even this may progress or regress depending on whether certain risk factors have been eliminated. Now, if you eliminate those risk factors, then it may regress. CIN1 most of the times may regress back to normal. CIN2 can regress in sometimes up back to CIN1, and then CIN3 rarely regresses. So if you have a CIN3, it's most likely to progress than it is to regress or become better. Now, there is a classification that was put out by many different individuals. Rubin had a classification. He's the one who actually coined the term carcinoma in situ before actually someone getting an invasive carcinoma. Then Walters and Regan in 1956 introduced the concept of dysplasia. Richard in 1967 actually brought the term CIN. Then in the year 1975, the WHO actually now classified the cervical intraepithelial neoplasms into 3 grades. So this is based on the thickness of the undifferentiated cells. So CIN1, you have mild dysplasia. That's going to be affecting the lower 1/3 of the base. I'll show you some pictures. Then CIN2 is affecting a half to 2/3 of the base, and then CIN3, which is the severe form, it's the whole thickness, which is just sparing maybe 1 or 2 superficial layers. Then carcinoma in situ is the entire thickness, but it hasn't yet crossed the basement membrane. There is also another classification system that's known as a Bethesda Classification system, which usually grades them as atypical squamous cells. You may also grade them as low-grade squamous intraepithelial lesions, which is abbreviated as LSIL. Keep this in mind. So this is going to be including changes that are seen in CIN1, and of course changes of HPV infection, which is the coilocytic changes. And of course you also have the high-grade squamous intraepithelial lesions, which all include CIN2, CIN3, and carcinoma in situ. So this should give you like a preview of what we're going to talk about. Now remember that CIN is pretty much predominant in younger women, so the mean age of carcinoma in situ is about 30 years, and about 15 years less than that of the invasive carcinoma. So if you add 30 years to 15, someone is around 45. They are almost close to the age where we actually make a diagnosis of cervical cancer. So you see what I was talking about, that this is going to be a process that's going to be happening over many years. And most of the times the CIN lesions actually tend to be asymptomatic, so you don't know that you have this until you actually get screened for this. So what's the classification of cervical dysplasia? So you may have the coilocytic changes, the nuclear atypia, and the increase in mitotic activity. You may have CIN1, which is mild dysplasia, CIN2, which is moderate dysplasia, CIN3, which is severe dysplasia. So in CIN1, you have 1/3 of the epithelium, which is affected. The upper 2/3 are normal. As you can see, the upper 2/3 are normal. The lower 1/3 is the one that is having this high nucleocytoplasmic ratio, prominent or pleomorphic nuclei, and of course these are affecting the lower 1/3. In 66% of the time, it's actually going to regress. So meaning that in 66% of the time, it's actually going to get better. Then that means that in 33% of the time, it can either remain static or it can progress further. Then you have CIN2, which is also affecting the lower half of the basal cells. These are going to be abnormal, and while the upper half is going to be normal. So the upper half of the epithelium is normal. The lower half is the one that is rather abnormal. This is going to regress in 33% of the time. It gets better in 33% of the time. It gets worse in the remainder of the percentage. Then you have the CIN3, which is going to be affecting almost the entire layer of the cervix, with only sparing maybe just the upper 2 layers of the cervix. So as we can see, there are also going to be a lot of mitosis, and this is unlikely to regress. So most likely it's going to progress to carcinoma in situ, and if it's not treated, it may take some years, it may take some months, but eventually it will penetrate the basement membrane. And once the basement membrane has been penetrated, then we refer to this as invasive carcinoma. Only then can we say this woman has cervical cancer. Then you also have your CIS, which is your carcinoma in situ. Remember that if it hasn't crossed the basement membrane, you call this as the carcinoma in situ. So it involves the entire epithelium. So we're going to have the entire epithelium being affected. There's going to be loss of satisfaction and polarity of the cells. There's going to be the cells that are going to be varying in size and shape. The nuclei are going to stain deeply, and there are going to be some frequent mitosis and abnormal chromatic patterns. The nuclei is large, it's hyperchromatic, and you get scanty cytoplasm, and of course the basement membrane still remains intact. This is the hallmark of a carcinoma in situ. It hasn't yet crossed the basement membrane. This rarely regresses, so it's most likely going to progress to invasive carcinoma. So remember that these pre-malignant lesions of the cervix are usually asymptomatic. So they progress to pre-malignant, then eventually become invasive carcinoma, and it takes roughly about 8 to 10 years. So the natural history of the cervical dysplasia rather depends on the response of this individual to the HPV types. So if they get a type that is likely to progress, like 16 and 18, then it will obviously progress, while as other types are just going to remain static and they won't progress to cancers. Now, what's the pathogenesis of the condition? Remember that the process of carcinogenesis is going to start off at the transformational zone. Remember that this part is not static, it's dynamic. It tends to move. Now, the reason why it tends to move, it's attributed to two mechanisms or two processes that are involved in the replacement of those endocervical cells, which are pretty much columnar, by the squamous cells. One way is the squamous metaplasia of the subcolumnar reserve cells. Remember that you have basal cells at the bottom of the endocervix, and these are like stem cells, so they are undergoing metaplasia and eventually are supposed to form the squamous cells. Then of course there is also squamous epidermization, which is going to be ingrowth of the squamous epithelial cells of the ectocervix under the columnar epithelium. So these are the two proposed mechanisms as to how the cells of the endocervix pretty much are replaced from columnar to squamous epithelium. So initially the squamous cells are going to be immature, but ultimately they may mature and they may be indistinguishable to the adjacent cells that are of the squamous epithelium. And remember that this metastatic process is very active at the time of menarche. It's very active during and after the first pregnancy. Then of course the periods of high estrogen exposure are going to lower the vaginal pH. How does this happen? Remember that estrogen is going to lead to an increase in vaginal epithelium accumulation of glycogen. Then this glycogen is going to be acted on by lactobacilli to produce an acidic pH. So the acidic pH is actually what is thought to actually trigger the changes that we see, the metastatic changes that we see from the columnar cells, which are more susceptible to the acid destruction, to squamous cells, which are rather more resistant to the acid destruction. Now, the metaplastic cells actually have a potential to undergo atypical transformation because of the trauma or the persistent infection. So the prolonged effect of the carcinogen actually produces these continuous changes in the immature cells, and this is actually what leads to the malignancy. So we have some risk factors like HPV infection, with persistent HPV infection, microtrauma that can happen during sexual intercourse. This can actually cause the viral particles to enter into the epithelium and into the basal cells, or even the parabasal cells. Then of course this is going to be affecting the transformational zone. So the transformational zone is the one that is most susceptible. Then of course the HPV DNA positivity is strongly related to the number of sexual partners. So women with multiple partners have high HPV DNA positive rates, as high as 60%, compared to those that have a single partner, which is roughly around 21%. And then the risk of progression from CN1 to CIN3 is estimated to be about 25% over 2-year period. And then of course the risk of progression to invasive carcinoma, it's quite difficult to quantify. However, in some women that have CIN3 who receive treatment which has been unsuccessful, about 30 to 40% of them develop invasive cancer within about 20 years. So what's our diagnostic approach? So here we have an HPV screening, or we'd rather have cervical cancer screening that we are supposed to undertake. There are some screening methods that can now help us pick out the cervical intraepithelial neoplasms and to help diagnose cancer early enough. Now, there is a Pap Smear which can be done, which is actually coincidentally the most successful screening test that has ever been discovered in medicine till date. So the Pap Smear can actually be done, and once you get an atypical smear, then you have to investigate this person any further. You have to investigate them further. So way back, we used to start them at the age of 21, but now the American College of Obstetrician and Gynecology has actually, or rather the American Cancer Society, not really the American Obstetrician and Gynecology, the American Cancer Society has now been changed this age threshold from 21 to about 25. So I'm not so sure if the American Gynecology Association has also changed, but according to the newer guidelines from the American Cancer Society, this has changed to the age of 25, or at least 3 years after the onset of sexual activity. But for academic purposes, for now, I just want you to learn the basics that we're there. So we usually start at the age of 21. And this is because most of the people already have some sexual activity way before even the age of 21. Then, of course, this is in our setting. Then you may also do HPV testing, which has a high risk for positive HPV DNA test. You may also perform colposcopy. We'll talk about that very shortly. So we should consider cervical cancer in all women that have visible cervical lesions, in all women that have abnormal routine Pap smear tests, in all women that have abnormal vaginal bleeding. This can include things like post-menopausal bleeding, intermenstrual bleeding, and even postcoital bleeding. Then, of course, further evaluation is going to be indicated if you get any atypical cells or cancerous cells which are particularly found in women that are at risk of getting cervical cancer. Now, let's talk about the Pap smear. So this was introduced by a Greek gynecologist that was by the name of Dr. George Papanikoulou. I know it's a very, very strange word to say, Papanikoulou. It's a Greek word. So this Pap smear is actually the gold standard screening test for cervical cancer. Now, it's actually the most successful screening test that has been developed in medical history till date. That's how effective it is if it's done right. So the smear itself is going to be containing cells from the squamocolumnar junction, the transformational zone, as well as partly from the endocervix. So you may use either an Aries spatula, I'll show you what an Aries spatula looks like, and an endocervical brush in non-pregnant women. In pregnant women, we use what is known as a Q-tip. So it's like an earbud. It has a wooden stick with some cotton at the end. And we can use this actually to get these cells from the transformation zone and from the endocervix. Then, of course, we're going to smear these cells on a glass slide. So this is what is referred to as a conventional Pap smear. But of course, there were some processes that we changed to make it much more effective. So we do this in a conventional Pap smear. We smear these on a glass slide. Then immediately we fix it in formalin. Then, of course, the Pap smear screening is, if the Pap smear screening is actually inadequate if the sample is not taken from the transformational zone. So you may get a false negative. You may tell this woman you can go, you do not have any cancer, but indeed she has cancer. Then, of course, the 80% of the sample that is collected is actually discarded. And because now it is discarded, then you may miss most of the cells and it may not give you an accurate diagnosis. And the efficacy is actually limited. Remember that the bulk majority of the cervical cancers that we're talking about are squamous cell cancers. 80% of them are squamous cell cancers. This screening method will not pick up the adenosine carcinoma. So it has a limited efficacy in picking up the adenocarcinomas, which are responsible for 20% of the cases that we see. So here's a Pap smear that was adapted. A big shout out to Kaplan Medical. So here you have the endocervical brush, and here you have your Q-tip, which is pretty much used in pregnant women. So it has a cotton wool and a wooden thing. So you make these circular motions, and then you make the same thing here to remove some of the cells and smear them on a glass slide. Then, of course, once you get the sample, you smear it on the glass slide. It's not really going to be representative of the cells that you've gotten from the cervix, because over 80% of the cells are actually going to be discarded, and then eventually the smear is spray fixed and sent to the lab. Of course, you fix it with formalin. It's very hard to read. It's very hard to get an accurate diagnosis. So this conventional Pap smear wasn't really an effective way of doing things. Now, there is now a modified type of Pap smear, which is known as a liquid-based preparation, or you can call it as a thin prep Pap smear. So this one, it's rather difficult to, why we want to do this, because the conventional Pap smear is difficult to read, because it's not really a single layer of cells. You get a lot of cells a lot of things that are going on. I think I added some slide comparing the two. So in a conventional Pap smear, you get a lot of cells on the slide. It's very difficult to read. But here, you get actually the cervical specimen, which is rinsed in some preserving solution. All the artifacts are removed, all the blood, the mucus, and every non-diagnostic debris is removed, such that you leave behind the cells. The advantage of this is that you get one layer of cells. Then there's no need for air drying this specimen, and we can actually do Hpv DNA testing on the residue elements that are left. So this is a much more better way, where we get the cervical specimen, Well, of course, virtually 100% of the collected specimen is rinsed in a thin prep vial. Then, of course, the sample is immediately preserved and is sent to the lab. And then in the lab, they perform a filtration process. Then, of course, they dispense they disperse randomized cells and they put them in one single layer. So it's very easy to actually look at these cells. Now, here is the difference. So as you can see here, you can easily spot out each of the cells because they're in one layer. But look at what's happening here. There's a lot that's going on in the conventional Pap smear. So it's very difficult to read, while the thin prep or the liquid-based Pap smear is easier to actually read. Now, there were some changes that were made to this, and I want us to actually, first I'll introduce the changes that were there before, then I'll talk about the new changes that are there. So now remember that the Pap smear should be initiated 3 years after the first sexual activity or at the age of 21 years. We should repeat this annually until the patient is aged 30, then every 2 to 3 years. If 3 consecutive smears are normal, then of course, or they may not even be consecutive, but ideally they should be consecutive, then of course the Pap smear may end at the age of 70 if there are no signs of cervical dysplasia. So this is what was there before the revised guidelines came in 2020. So now in the revised guidelines that came in 2020, the first thing is that the screening is not starting off at the age of 21, but it's rather starting off at the age of 25. So if the primary HPV DNA testing is available, then it should also be started at the age of 25 as opposed to 21, or as opposed rather to 30, because usually we started at 30 years, the HPV DNA testing. We now brought down the threshold to 25. So we start the HPV DNA testing at 25. We also start the Pap smears at 25. Then of course, this should be done every 5 years. If the HPV DNA testing is not available, then we should do a Pap smear every three years. So this is still been maintained the same. So we do a Pap smear every 3 years. Then of course, you may also co-test with HPV and then Pap smear, which is done every 5 years after this. Then of course, the Pap smear testing and the co-testing should be phased out when you have the primary HPV testing that becomes available. So there is no need for you to actually do the Pap smear routinely if you can actually do the HPV DNA testing. And for women that are over the age of 65, then the guidance remains the same. So the test is stopped if the results have been normal in the preceding 10 years. And of course, the test should be continued if the results have not been normal in the past 10 years. So these are actually the changes that were actually introduced to this screening method according to the Cervical American Cancer Society in 2020. Okay, so abnormal Pap smears is going to obviously be followed by what is known as a confirmatory colposcopy. So we do what is known as a VIA, visual inspection under acetic acid, with or without a biopsy. So here's how you're going to be doing things. So number one, you do your Pap smear, and if you get an abnormal Pap smear, then you can repeat it after some time, after of which you're going to want to offer this patient confirmatory colposcopy. So this usually uses visual inspection under acetic acid. You apply vinegar to the cervix, and then of course the areas that stain white, you biopsy those areas and you send them to cytology. You may also do HPV DNA testing. So it means that some screening methods that we're going to be using in cervical cancer include your number one, your Pap smear, number two, your visual inspection under acetic acid with colposcopy, plus or minus biopsy, then of course, number three, your HPV DNA testing. Those are the methods that you're going to be using. Alternatively, if you do not have the acetic acid, you may actually use what is known as a Schiller's test, which uses a solution of iodine. And then the cells which actually don't stain with iodine, the ones that remain pink, they're not stained brown, that's where you biopsy. I'll show you what these all look like very shortly. So you may also see features of dyskaryotic cells on Pap smear. So there may be an increase in size. There may be pleomorphism. So there may be different staining characteristics or appearances. The cells are going to be varying in size and shape. There may be multiple nuclei. There may be clumping of chromatin of varying degrees. There may be aneuploidy. You may have this alteration in the nuclear membrane. There may be a perinuclear halo. So these dyskaryotic changes are going to be atypical cells with a hyperchromatic large nuclei that has abundant cytoplasm. So in mild dyskaryotic smears, we correlate this with pretty much CIN2 and CIN3 in about 50% of the cases. Then in severe dyskaryosis, it correlates in about 90% of the cases with CIN2 and CIN3. Then of course, carcinoma in situ is going to be showing you this hyperchromatic nuclei with coarse chromatin, less cytoplasm, and then of course there may be some multiple nuclei and abnormal mitotic figures. Now here is the Bethesda classification, the Bethesda 3 classification, which was introduced as of 2001. So you get a negative test if the cells are small, they have a pycnotic normal looking nuclei. Then of course you may sometimes get what is known as atypical squamous cell of uncertain significance. So you do not really know if these are malignant or they're not, or they're normal, so you're rather in between, but there's something wrong with them. So this should be seen in roughly around less than 5% of the Pap smears, but they may be even as high as 20% of the Pap smears. So us doing a thin prep can actually reduce having these atypical cells of uncertain significance. You're not so sure where to classify these cells. And then of course, Hpv DNA testing should be done on the residual cells, and the patients with high risk of Hpv should be followed up with colposcopy and biopsy. If they are low risk, then you should perform this follow-up in 1 year. Then of course you may get atypical squamous cells where you cannot really rule out a high-grade lesion. So it's known as ASK-H. This is known as ASK-H. Then you may get low-grade squamous intraepithelial lesions, which usually correlates with CIN1 or mild dysplastic changes. Then your high-grade squamous cell intraepithelial lesions are going to be correlating with CIN2 and CIN3, so where you have moderate to severe dysplastic changes. Then of course you may have cancer, which is your invasive. So each of these have different management schematics, or how we actually manage these different cases. I know this lecture is going to be so long, but stick around until the end. I promise you it's going to be worth it. So you may have your ASCUS, which is your atypical squamous cell of uncertain significance. So here, what do we do when we get this? We repeat the Pap smear. Of course, we can use a thin prep, liquid-based Pap smear. This will actually reduce the incidence of us getting these atypical squamous cells of uncertain significance. Then of course, if the Pap smear on the thin prep still shows this, then we have to perform our Hpv DNA testing. Then those that are at high risk, those that have 16, 18, 31, 33, and 35, we confirm with colposcopy and biopsy. Those that have low risk, 6 and 11, we follow them up with another Pap smear within a year. Then of course, those that have a typical squamous cell that you can't really rule out any high-grade lesions, or those that have low-grade squamous intraepithelial lesions or high-grade squamous intraepithelial lesions or cancer, we usually want to perform colposcopy, where you send that to histology. Now, the Pap smear is not a diagnostic test, so it should always be followed up by colposcopy and biopsy. Pap smear is a screening test. It's not diagnostic. You can't say someone has cancer based on a Pap smear, because you're just getting cells. You're not getting the entire picture, so you need a biopsy of the entire picture. So the Hpv DNA testing actually checks for the detection of high-risk types of Hpv, and you can do this within hours. Then only about 2 to 5% of women diagnosed with Hpv will ever develop CIN. So nearly 80% test positive will clear out the infection, but those that are immunocompromised are going to remain with this persistent infection. So positive test results in elderly women, those that are greater than the age of 30, this may suggest that you may get a colposcopy. Remember that according to the newer guidelines, we should start this Hpv DNA testing at the age of 25. Then of course, the Hpv DNA testing is an adjunct to your cytology. So you may have a quantitative HPV testing, which is more important compared to the qualitative result. The qualitative result just shows you that, okay, you do have HPV. Quantitative also even shows you the types. It also shows you the load that you have there. So now if you just look at the percentages of how much we're going to be getting to detect the high-grade squamous intraepithelial lesions, which are your CIN2 and CIN3. If you just do a conventional Pap smear, in about 51% of the time you will get this diagnosis. If you do a liquid-based thin prep, you get the diagnosis in about 80%. Then of course, if you combine Hpv DNA testing with a Pap smear, you get the diagnosis almost 100% of the time. Then we may also perform biopsy. So you want to perform VIA, visual inspection under acetic acid. So a speculum is introduced, then of course acetic acid is applied to the cervix, and then you wait for a minute. Then those that have this aceto-white lesions, we consider them for biopsy, colposcopy examination, and of course biopsy. So colposcopy is pretty much in situ examination of the cervix. So you have low magnification, 6 to 16 times microscopy. And of course, it is complementary and it's not a substitute for cytology. This should not be used to substitute cytology. You must always get a biopsy that you send to cytology. So cytology is a lab method and colposcopy is a clinical method of detection. Now the cytology is going to be rather evaluating the morphological changes of the exfoliated cells. Then of course the colposcopy eventually or rather evaluates mainly the changes of the terminal vascular network of the cervix. You may see some abnormal changes, I'll show you those, which may reflect some biochemical and metabolic changes in the tissues. So in fact, cytology actually identifies that the patient has a cervical neoplasm, while colposcopy only just identifies the site where you should biopsy from. So indications of colposcopy include an abnormal cytology. You may even have a grossly abnormal cervical lesion, even if the cytology is negative, or even postcoital bleeding, even if your Pap Smear is negative. You want to do colposcopy, you want to do biopsy. So what are the findings that you may see when you now get your colposcope and you look at the cervix? So it may be a satisfactory colposcopy, maybe normal, where you are visualizing the original squamo-columnar junction, the columnar epithelium, and the transformational zone in its entirety. There's nothing wrong. There's no pathology that you can see. Or you may get some abnormal findings. You may get some white epithelium, which we call leukoplakia. You may get aceto-white epithelium. Of course, the epithelium turns white when you apply the 5% acetic acid during the cell protein coagulation. Then, or this is due to the cell protein coagulation. You may get some punctation where there are dilated capillaries which are on the surface, they look like dots. So you're just simply viewing the ends of these vessels. You may get a mosaic appearance where you get the capillaries encircling polygonal shaped blocks of epithelial cells. All these are areas of possible biopsy. Then of course you may get atypical blood vessels with irregular diameter, and then of course they may be branching. This may be suggestive of invasive carcinoma. You may get an irregular surface contour, ulceration, and even friability. Now this is a colposcopic view. As you can see, there is this aceto-white epithelium that you can see here. So these are all areas of possible biopsy. There should be something wrong with these areas. Here is of course the external os, and then here you have the external os. Here you even have a mosaic pattern, a typical mosaic pattern. This is what it looks like on colposcopy. So the biopsy actually revealed that this person had a carcinoma in situ. Then of course you may get these atypical vessels, which usually are significant of invasive carcinoma. So these are the patterns that you may see on colposcopy. So you may see your white pattern, your mosaic pattern, your punctations. You may also see these abnormal blood vessels. All these are going to be seen, these changes are going to be seen in the transformational zone. Remember that the transformational zone is what is between the endocervix, which has columnar epithelium, and the ectocervix, which is obviously going to be having your stratified squamous. Then this transformational zone is where you have a change that's coming from the columnar cells going into the stratified squamous epithelial cells. Now during your you may sometimes perform a cervicography where you take photos of the cervix, and the film is actually going to be viewed by an expert colposcopy. Then of course, similar to colposcopy, the cervix is treated with 5% acetic acid before you take the photograph. And then of course it's complementary to cytology. It's also complementary to colposcopy. It's another thing that you can do. So you may sometimes do a biopsy with or without colposcopy. So if colposcopy is available, then colposcopy detects an abnormal area, then the biopsy is taken under the guidance. So this is known as a targeted biopsy. It's much better than a blind biopsy. A targeted biopsy, you are able now to biopsy exactly where the problem is, exactly where the lesion is. So there's a higher rate of you getting what you're looking for. Then of course you may have where the colposcopy is not really available, so you may perform a Schiller's test, which are going to be using iodine solution. So you may either use Schiller's 0.3% solution or Lugo solution, which is potassium iodide, 5%. You may get multiple punch biopsies to the areas that are not stained. Remember that the areas that stain brown are normal. They are staining brown because there is glycogen in those areas, and the glycogen is uptaking the iodine. Then of course, alternatively, You may do what is known as a ring biopsy, which is taken from the squamo-columnar junction, and you get these seriosection, multiple sections. Of course, this is not going in blindly. You may not even get what you're looking for. You may sometimes perform an endocervical curettage, which is mandatory whether or not the entire transformation zone can be seen. Now, the cervical glandular intraepithelial neoplasia, or CGIN, of the cervix is rather rare. Now, this one is affecting the glands, not really the other cells of the cervix. Then, of course, screening with cytology and coposcopy is usually unsatisfactory, so a cone biopsy is going to be diagnostic for those that have high-grade cervical glandular intraepithelial neoplasia. So you may do what is known as a cone biopsy. Now, diagnostic colonization of the cone biopsy is needed. Actually, the need for this has actually reduced to at least 80% because of the introduction of the coposcopy-directed biopsies. So in some cases, you may actually want to perform a diagnostic colonization. If coposcopy is available, when can we do this diagnostic colonization? Number one, if you can't really see the entire limits of the lesion, we can do a colonization. If the transformation zone is not seen, you can do a colonization. If there's evidence of microinvasion on the biopsy or coposcopy of cytology, we may do a diagnostic colonization. If there's significant CIN on endocervical curettage, or if there's a normal coposcopic findings with abnormal cytology or a biopsy, if there's a lesion growing into the endocervix, or if there's a high-grade cervical glandular intraepithelial lesion, we may perform a diagnostic colonization. Then, of course, a coposcopy, if it's not available, then if you get an abnormal smear with a healthy cervix, do a diagnostic colonization. If there is a positive diagnosis of CIS, carcinoma in situ, to exclude invasive carcinoma, you should do a diagnostic colonization. Of course, if the biopsy report is inconsistent with the cytological findings, then we should do a diagnostic colonization. Remember, when I say that the Bethesda classification must go hand in hand with what you get on your Pap Smear, it must go hand in hand with, of course, the cervical intraepithelial lesion that you have. Then, of course, the risk of deep cone biopsy include things like incompetent cervix. So it may cause this woman to have an incompetence of the cervix. It may cause this woman to have cervical stenosis. This is just some of the risks of performing a deep cone biopsy. Now, how do we manage the patient that comes in with CIN, CIN1, CIN2, CIN3, CIS? We haven't yet gotten to the invasive carcinoma. So definitive management largely depends on the age of the patient, the desire for reproduction, the risk factors that are present, the degree of dysplasia, and of course, if the facilities are available to follow up this woman, facilities such as a coposcopy, facilities such as cytology. Now, the modalities of management, usually we can observe and repeat the smear and coposcopy every 4 to 6 months. We may perform some local ablative methods. So the following criteria should be fulfilled. So number one, the entire lesion should be visualized within the transformational zone. That's when we can actually use these local ablative therapies. Number two, there should be evidence of no evidence of microinvasion or invasion. Number three, there should be no endocervical glandular involvement. Number four, there should be no discrepancy between the cytology, the coposcopy, and the biopsy. Then if the person ticks all these 4 criteria, then we can use local ablative methods. Some contraindications include suspected invasive lesions or glandular disease. They have to be investigated further. If there is a squamo-columnar junction that you can't see clearly, you can't use these local ablative methods. If there's a discrepancy in the smear and the coposcopy as the biopsy findings, you can't use these local ablative methods. Then, of course, we have some excision methods that are also used. These methods are also used in the early stages of cervical cancer as well. So what are these local ablative therapies? So we may perform cryotherapy, where we use, of course, our liquid nitrogen. So the principle here is that you want to crystallize the intracellular water at a temperature of about -90 degrees using nitrous oxide or even carbon dioxide. Then, of course, this causes a depth of tissue destruction of about 5 millimeters. So this method is ideal for the minor degrees and the local CIN lesions. And then, of course, a double freezing technique increases the effectiveness of the cryotherapy. It's one way in which we can use. We can also use cold coagulation, where we destroy the cervical tissue with a temperature of 100 to 120 minus 100 to minus 120 degrees Celsius. Then, of course, it's not done Yeah, it does not need any anesthesia, and the depth of the tissue is actually about 4 millimeters that we destroy. We may use electrodiathermy, which destroys the cervical tissue in about 8 to 10 millimeters diameter or depth, and this uses, of course, a unipolar needle electrode. So this is done under general anesthesia. We may also use laser vaporization, where we use carbon dioxide laser through a coposcopy guidance, and we actually destroy the epithelium by vaporizing it, and can actually go to a depth of about 7 millimeters. Then this is the method of choice actually when we are using your cervical intraepithelial neoplasms. The advantage of this laser is that, number one, it's going to preserve your transformational zone for subsequent follow-up. Number two, the precision control technique in depth and breadth. And of course, the third thing is that the healing is actually very, very rapid. So we may also use excision method. We may use what is known as a large loop or an electrosurgical excision of the transformational zone. Or we can use a loop electrosurgical excision procedure. So a loop, which is about 2 to 3 centimeters, it's a very, very thin stainless steel wire. We pass this, and we can actually use this to excise the transformational zone. So the blended current, which is both cutting and coagulation, we use low voltage, and this is very simple. It's a very quick procedure to do. It's done under local anesthesia. Then, of course, the tissue depth is about 10 millimeters, and you can even remove more, and this can be sent for histological examination. Of course, complications are minimal as compared to the cone excision, which can actually cause your cervical incompetence. It can also cause cervical stenosis. Then, of course, cone excision is what we're going to be using. It's known as a cold knife. This uses either a knife, a cold knife surgery, or it can use a laser. So when a cold knife conization is commonly done, we use this in our setting. Then the laser excision cone biopsy is rather preferred, as it can be done in outpatient under local anesthesia and using coposcopy guidance. The blood loss is also less with this. Then, of course, the conization of the CIN is actually as effective as hysterectomy, provided the margins are free of any disease. So when you send this to histology, you should get back a report that your margins are free of any disease. If they are not, this patient has to be reviewed again. Then, of course, the complications include hemorrhage, infection, cervical stenosis, incompetence, depending on the length of the cone that has actually been excised. So this is the leap, which you're actually just taking here and passing current, coagulation, and cutting right through and removing this section of tissue. Then, of course, the cold knife biopsy is, you're of course cutting now with your cold knife and removing the section of tissue. We may also sometimes perform a hysterectomy, which can either be done abdominal or vaginal. So the CIN lesions are associated with other gynecological problems such as prolapse, fibroids, pelvic inflammatory disease, endometriosis. CIN that's extending into the vagina. If you have persistent dyskaryotic smear, even with treatment, high-grade cervical glandular intraepithelial lesions in elderly women, we do hysterectomy. Patients who have CIN3, patients with poor compliancy for follow-up, those that have cancer phobia, those, you should note that the vaginal cuff is, removal of the vaginal cuff is going to be done, and if the lesion extends to the vaginal fornices. So here's the management by the different stages of CIN1, CIN2, as well as the CIN3 and CIS. So in CIN1, so the woman with CIN1 confirmed by biopsy is kept under observation with, of course, your Pap Smear that you follow up at 6 months, or Hpv Dna testing that you do at 12 months after you make the discovery of CIN1. Then, of course, if both tests are negative, then you do your routine screening as we've already followed up this patient. Then, of course, CIN1 can be managed by your ablative therapies. It can also be managed by excision. CIN2, on the other hand, the fact that over a prolonged follow-up, about 10 to 15% of CIN1 actually progresses to CIN2, then to CIS, which is carcinoma in situ, then again, it is quite impossible to predict whether this woman is going to progress, or they're going to regress, or they're going to remain the same. So we usually treat those that will come in with CIN2, we usually treat those that will come in with CIN3 and even CIS. So you want to manage this also with local ablative therapy and even excisions. CIN2 is commonly treated with your loop methods. Then, of course, you may have CIN3 and CIS. So the basic concept here is that the cervical intraepithelial neoplasms, is a superficial lesion. So complete destruction of the lesion is considered as satisfactory for treatment. So pre-treatment accurate evaluation must be done to examine the extent of the lesion and to exclude any invasive carcinoma that may be available. So CIN3 is going to be managed by ablative and even excision methods. Hysterectomy is actually the recommended for recurrent CIN2 and CIN3 in women that have do not have desire to actually give birth. So here's a schematic of how things are done. So cervical smears should be done in all active women between the age of 18 to 60, though this was actually increased to somewhere around 25. So if it's normal, repeat the smear after 3 to 5 years. If you get dyskaryotic cells, if it's CIN1 or mild, you repeat the smear after 6 months. Then, of course, abnormally persistent and Hpv Dna testing will warrant a colposcopy and biopsy. If it's moderate or mild, if the colposcopy is available, you do colposcopy. If it's satisfactory colposcopy, then you perform a directed biopsy. Then if it's CIN1 or CIN2 or CIN3, you observe them or follow up. You may do some local ablative methods, excision methods, and even hysterectomy, then follow up with cytology and colposcopy. If it's microinvasive carcinoma, then of course, if it's not exceeding 3 millimeters, then of course therapeutic conization or a simple hysterectomy can be done. If it's exceeding 3 millimeters, radical surgery and radiotherapy should be done. Same thing with invasive carcinoma. Then of course, we may also do, if colposcopy is not available, we may do a 4-quadrant biopsy, or may do a biopsy with a Schiller's test. We may also do a cone biopsy. Of course, there's an increased risk of bleeding with this. If you get your inflammatory cells, then of course, the high vaginal or cervical swab for infection study. And of course, we treat the patient and her husband, repeat the smear in 6 weeks. If there's an unsatisfactory smear where the smear was having too little cells, or it's too thick, or excess blood, or the endocervical columnar cells, then repeat the smear as early as possible, preferably at the mid-cycle of the menstrual period. Then there are some vaccines that can be given. So at the moment of this presentation, before I actually went through the newer guidelines, the 2020 guidelines, we were actually giving 2 proposed vaccines, but now there are 3 proposed vaccines. So there is the bivalent vaccine, which has HPV 16 and 18, which are the most common causes of cervical cancer. We call this the name of the trade name of one of the vaccines. Then of course you may have a quadrivalent vaccine which protects you against 6, 11, 16 and 18. So this is effective in preventing 90% of the cervical cancer. Then of course we also have a 9-valent vaccine which has 9 subtypes, 31. So it's 6, 11, 16, 18, 31, 33, 45, 52 and 58. So we may give this vaccine which has these. So both of these vaccines have some protection against 31, 33 and 45. And who should actually get the vaccine? Those that are between the ages of 12 to 18 years. We give it 3 doses IM over the deltoid. Then of course the impact of the vaccine has greatly reduced the risk of developing cervical cancer. So the vaccine is actually safe. It's well tolerated, and it actually induces neutralizing antibodies, your IgG and your IgM, or rather your IgG and your IgA, which prevent the cervix from being invaded by the HPV. And of course, the immune defense is a type specific, and of course, it's effective only when given prophylactically. So the vaccine is actually effective for at least about 7.5 years. Then of course, the screening with Pap Smear should continue. Even though you give them the vaccine, it doesn't mean you should stop screening them. Continue screening them regardless. So other measures include delayed sexual exposure until the cervical epithelium, especially the transformational zone, has attained its physiological maturity, maintaining local hygiene and treating vaginal infections, use of condoms specifically during early sexual life, maintaining penile hygienes for the men. You can actually advise them to get circumcised, as this may be reservoirs for high risk HPV carrying. Then of course we reduce or we quit smoking to reduce cervical intraepithelial neoplasms. Now the prognosis, the recurrence rate is about 3 to 5%, and development of invasive carcinoma is about 0.1 to 0.4%. And any recurrence of the vaginal intraepithelial neoplasia is diagnosed with colposcopy, followed up with the appropriate treatment could be the excision, biopsy, carbon dioxide laser therapy, or even topical fluorouracil. So I shall first pause the video here and then come back and continue, because it's been a long lecture and I think I should also take a break. So I shall. Alright, let's now get back to the lecture. So now let's progress and go now into cervical cancer. Remember that most patients that get the cervical intraepithelial neoplasms are pretty much going to be having no symptoms. So they will be asymptomatic. And the large majority of the patients that have actually invasive cancer, in some cases they may be symptomatic. In the early phases they may be symptomatic. Now remember that most of the cervical cancers are friable. You get a vascular mass on the cervix and likely to produce a number of symptoms. So in the early phases, there may be no symptoms. There may be postcoital bleeding. There may be a brownish discharge. There may be intermenstrual bleeding. There may be postmenopausal bleeding. There may be even a blood-stained vaginal discharge. In the middle stages, there may be post-void bleeding. There may be dysuria. There may be hematuria. Then the advanced stages where the cancer has even spread, there may be weight loss, loss of appetite, bloody or malodorous discharge, severe pain, which is obviously due to spread to the sacral plexus, back pain, leg swelling, which is secondary to blocked lymphatics. Now, any woman that's presenting with the symptoms that we've just undergone, we should take a full history, we should perform an abdominal pelvic examination, and we should also visualize the cervix. So in advanced disease, that's stage 3 to 4, patients may experience a number of distressing symptoms like pain, which is due to malignant infiltration of the spinal cord, incontinence, which is due to a vesical vaginal fistula, anemia, which is due to chronic bleeding, hydronephrosis, and post-renal failure, which is due to infiltration of the bladder and blockage of the ureters. Now, the initial clinical assessment of the patients may be unrevealing, as the disease can actually be localized and may not be visible even in the advanced disease states. And of course, a pelvic and speculum examination usually is going to clinch the diagnosis of a cervical mass, which is going to be bleeding on contact. If it's actually an advanced disease, there may be some hardness and fixity of the tissues, and then of course a biopsy can be taken in the outpatient department. Then remember that the large majority of the cancers are squamous cell carcinomas. 80 to 85% of them are the squamous cell carcinomas. They can be keratinizing, they may be non-keratinizing, so these tend to be well demarcated tumor with the stromal borders. Then of course they may be small cell carcinomas. These are small round spindle shaped cells with poorly defined tumor borders. These are also not so common. Then adenocarcinomas, which are accounting for 20%. You may also have the sarcomas and the small cell neuroendocrine tumors. These are very, very rare. Now remember that both the adeno and the squamous cell carcinomas are related to HPV high risks. That's 16 and 18. And remember, these are coding for E6 and E7. We talked about this in details earlier on. And of course, the tumors are going to be locally infiltrative in the pelvic area and also spread via lymphatics, and in the later stages via blood vessels. Then spread via blood vessels is very rare. The tumors can actually grow through the cervix to reach the parametria. You may get anatomical area lateral to the cervix. You may also get this spread into the bladder, to the vagina, and to the rectum. Then metastasis can also occur to the pelvic, that's the iliac and the obturator, as well as the para-aortic lymph nodes. And in the later stages, they can spread to the lungs as well as to the liver. If the cancer actually spreads to the pelvic and the para-aortic lymph nodes, then the prognosis is worse. The location and the size of the radiotherapy field is actually going to be affected in these cases. Now, what investigations are we going to do to help us clinch the diagnosis of cervical cancer? Or rather, the gold standard is to screen and pick out the dysplasia before it actually gets into a carcinoma. So a Pap Smear is your gold standard. It's actually the most successful developed test up until date. So the Pap Smear screening is inadequate if the sample is actually not taken from the transformation zone. Then of course, in as much as we do the Pap Smear for these other screening tests, it's only just going to be relevant for this the squamous tumors. The adenocarcinomas, which occur in 20% of the times, may not be adequately picked up by a Pap Smear. Then of course, your abnormal Pap Smear is going to be followed up by confirmatory colposcopy, that's visual inspection under acetic acid like we talked about, and biopsy. Then metastasis of cervical cancer can happen by direct extension, so it can spread to the rectum, it can spread to the intra-abdomen, it can spread to the bladder, even to the endometrium. It can also spread via hematogenous spread to the breast, to the lungs, to the bone, and to the liver. Then what's our differential diagnosis? It includes things like cervical ectropion, polyps, Nabothean cysts, papillary endocervicitis, papillomas or inflammation, vaginal malignancies. Tuberculosis may present in a proliferative form, and also other chronic granulomatous infections like syphilitic chancres, granuloma inguinale, and other infections. Now, what about our FIGO staging? So this is a clinical staging and it's not really a surgical staging. So there was an initial stage which was actually proposed in 2009, but then this was later revised in 2018, where we now even include certain radiological investigations in the staging. And then, of course, we also have that TMN staging that was also revised recently. We no longer consider the depth, but we usually consider the breadth. So like in the revised 2018 staging, we're going to be actually looking at the certain investigations like the ultrasound, the CT scan, the MRI, the PET scans. That's your PET CT, your PET MRI, and these are actually going to be giving additional information about the tumor size and the nodular involvement. Then, of course, the horizontal spread of the tumor, not the depth, rather the horizontal, the breadth. The horizontal depth of the tumor is no longer considered as part of stage 1A and stage 1A1 and also stage 1A2. So we no longer divide it into that. And then, of course, stage 1 is divided into 3 subgroups. Stage 1B is, you have stage 1B1, you have 1B2, or rather 1B2, and you have 1B3. Sorry about that confusion. So 1B1, 1B2, 1B3. Okay, I'll come to the staging very shortly. So this same staging is going to be including examination under anesthesia of the rectovaginal epithelium to assess the size of the tumor, the parametrial spread, the extent or the extension into the rectal vagina and the septum, the coposcopy, endocervical curettage and biopsy, hysteroscopy to evaluate the uterine lining, cytoscopy, sigmoidoscopy, proctoscopy to assess the bladder and bowel involvement, chest x-ray to relatively lung mets, liver function test to relatively hepatic involvement, evaluate the genital tract by the cystoscopy, intravenous urography, a CT scan with intravenous contrast dye, of course, for you to do this FIGO staging. Okay, now this was the previous classification that I've shown on the screen. There are some modifications that we changed to this classification as of 2018. So stage 0, which is your CIN3 and your carcinoma in situ. So here it remains within it hasn't crossed the baseline. It's confined to the cervix. So now these are the key statements that I want you to keep in mind with this staging. Stage 1, the cancer is going to be confined to the cervix. Stage 2, the cancer is going to be spreading to the upper 2/3 of the vagina or into the parametrium, but not as far as the pelvic wall. Stage 3, the cancer is going to be growing to the lower 1/3 of the vagina or into the parametrium or as far as the pelvic wall. Stage 4, that's where you have metastasis beyond the true pelvis or a growth that has involved the bladder or the rectum. So it's involving the bladder or the rectum, you classify that as your stage 4. Okay? Now, looking at stage 1, the change that was made at stage 1 is that we no longer consider the horizontal spread of the tumor as the stage. So we only consider the depth. So you can forget about this tumor no wider than 7 millimeters. We no longer consider this. We only consider the depth. So a tumor that is on stage 1A is going to be invasion into the stroma that is equal to or less than 3 millimeters. Then stage 1A2 is one that has a stroma greater than 3 millimeters, but not more than 5 millimeters in depth. We no longer consider the width. We no longer consider the breadth. We only consider the depth of the tumor. That's one stage that was actually one thing that was actually revised. Then, of course, the stage 1B here is divided into 3 subtypes. You have 1B1, 1B2, and of course 1B3. So 1B1, the lesion is actually going to be confined to the uterus, and it's actually the cervix, rather, not the uterus, the cervix, and it's going to be now less than 2 centimeters. So that's one thing that is there. Then the 1B2, which was previously the 1B1, is now going to be between 2 centimeters and 4 centimeters. I hope you're noting the differences with the newer classification. Then the 1B3 is obviously going to be greater than 4 centimeters, which is what was previously 1B2. Now this is 1B3. That's another change that was actually made to this classification. There are now 3 subgroups here under stage 1B. So there's 1B1, 1B2, and 1B3, and I want you to know the numeral classification. 1B1, the depth of invasion is less than 2 centimeters. 1B2, it's between 2 to 4 centimeters. Then 1B3, it's greater than 4 centimeters. Then of course your stage 2 is stage 2A. There's no parametric involvement, so stage 2A1 is less than 4 centimeters, stage 2A2 greater than 4 centimeters, then stage 2B is actually involving the parametrium. Then in stage 3, you have stage 3A where there's no extension to the pelvic sidewall but involves the lower third of the vagina. Stage 3B extends to the pelvic sidewall, causes hydronephrosis or a non-functional kidney. Then stage 4A is the cancer spreads to the adjacent pelvic organs. Then stage 4B, it spreads to the distant organs out of the pelvis. Now there are some changes that were also made to this. So lymph node status is actually part of the staging system. So those that have positive pelvic lymph nodes are now considered as stage 3C. So there's another stage 3C that was added here. So stage 3C1. Then those that have the pelvic lymph nodes, you call them as stage 3C1. Those that have the para-aortic lymph nodes, you call that as a stage 3C2. So these are just some of the important changes that were actually made to this NOAA system. So just have a look at that. I haven't showed it on your screen here, so just Google it up, look at the 2018 FIGO staging of cervical cancer because it was revised. This was a previous classification that I'm giving you at the time of this recording. Then there is tumor grading. Remember the difference between tumor staging and tumor grading is tumor staging is pretty much the extent of the tumor, the size and the spread. Then tumor grading is pretty much the level of differentiation. So grade X you can't really assess. Grade 1, there is invasive. With an invasive squamous tumor, it's well differentiated. With the adenocarcinomas, there is a small component of solid growth and nucleus atypia. There's mild to moderate. Then, of course, grade 2, with the invasive squamous tumors, they are moderately differentiated. With the adenocarcinomas, the intermediate grade of differentiation. Then grade 3, these invasive squamous tumors are poorly differentiated. The adenocarcinomas have a solid pattern, severe nuclear atypia that predominates, and then grade 4 are undifferentiated. Grade 1 have a good prognosis, grade 4 have a rather poor prognosis. So what are the management principles? So patients may actually undergo definitive treatment only if the disease is confined to the pelvis. That's the first thing. Patients may undergo, with local recurrency, may actually undergo a radical hysterectomy, and they are also treated with radiotherapy. Then patients previously treated with radiotherapy are treated only by radical pelvic surgery. Now the treatment depends on 3 things. It depends on the age or the general condition of the patient. It depends on the extent and the type of the lesion. It also depends on the experience, resources, and the personnel that are involved on the oncology team. Of course, the renal function should be done. The blood ureas and the intravenous urograph, urinary infections should be present and they should be treated. Then of course anemia should also be treated. Ultrasound, CT scans can be used to identify the lymph nodes with the newer classifications. Then of course examination under anesthesia is very important to examine the extent of the clinical growth of the tumor. Of course hysteroscopy, curettage can be performed and biopsies can be taken. A rectal examination is very important to exclude involvement of the rectum. And then of course the clinical extent of the growth in the parametrium is also more easily felt in the rectum. Then of course cystoscopy excludes involvement of the bladder. Now radiotherapy, so this is the first line in advanced stages or poor risk patients. It cannot be used if the bladder is invaded, as it may result in fistula formation. Then cesium is actually used using various techniques. So the most common technique is what is known as the Stockholm Technique, or one of its modifications. So you get a tube containing 50 milligrams of cesium, you put it into the uterus, and 2 ovoid or flat boxes containing a further 60 milligrams are packed into the vagina. Then of course care is taken to give minimum dose of radiation to the rectum. Then of course the cesium is left for 22 hours and 3 applications are usually given. So the second a week after, and the first, and then the third is going to be given 2 weeks after the second. Then of course the older regimen has now been replaced with the use of cathetron, which is an empty container which is inserted into the uterus and the vaginal fornices and clamped into position. Then its position is checked and several high intensity cobalt sources are afterloaded and deliver the radiation. Then of course the apparatus is contained in a sealed unit and the radiation delivered by remote control. So this actually eliminates the danger to the staff that are administering this. Then note that cesium may be used in pre-malignant or as a preliminary rather to surgery, or it can be combined with external beam radiation to the lateral pelvic walls. Then of course advanced techniques such as cobalt or the linear accelerators can actually be used, but I won't go into details of those. Surgery is usually confined to those that are in stage 1 and some cases of stage 2. So those that are at stage 2B and stage 2A. So with thyma radical abdominal hysterectomy is the treatment of choice. So we remove the uterus, we remove the tubes, the ovaries, the broad ligament, the parametrium, the upper 2/3 or the upper half or 2/3 of the vagina, and the regional lymph nodes. And of course chemotherapy, we use platinum, vinblastine and bleomycin as a combination with radiotherapy. So everyone that's above the stage 2, we actually treat them with either the radiotherapy or chemotherapy. Then we may sometimes do pelvic exanteration, which is used for advanced cases where the carcinoma has spread. So extensive surgery must be undertaken as the only hope for cure for the patient. Then of course it is reserved for patients who are of good health with extensive disease involving the bladder and the rectum. So we may perform an anterior exanteration where we remove the uterus, the adnexae, the vagina, the bladder, the urethra. The ureters are implanted into the colon or are into an ileal loop opening into the abdominal wall. Then of course posterior exanteration removes the uterus, the adnexae, the vagina, the descending colon, the rectum, and leave a colostomy. So this is suitable for posterior growths involving the colon or rectum. This is a rather very destructive procedure. So in a total exanteration, the two procedures are combined and the patient is often left with an ileal loop and a colostomy. Now treatment by the stages, remember stage 0, stage 1, we can use the local methods, your laser or cryotherapy, your loop electrosurgical excisions. You may also use your cold knife biopsy, your total abdominal hysterectomy. Then of course this is the patient, if the patient has completed childbirth, colonization or cryotherapy, if the patient wants to retain the uterus for function of giving birth. Then of course stage 1A, stage 2A, modified hysterectomy can be done, or radiation, pelvic lymph node adenectomy, and as well as para-aortic lymphadenectomy. Then of course anyone that's above this, we want to use your chemotherapy with cisplatin and radiation. Now the results of the treatments, so patients are examined every 3 months for the first 2 years, and then every 6 months in 3 to 5 years, and then yearly after that. So an exam is going to be consisting of a history, a physical examination, a Pap Smear, and a chest x-ray, as well as a CT scan of the abdomen, which should be done annually. Then with early diagnosis and treatment, about 80% of stage 1 cancers are cured in, and about 10% of stage 4. Then of course 30% of the patients treated with cervical cancer will have recurrence. So reoccurrence of the cancer can actually occur anywhere, but it occurs mainly in the pelvis, the vagina, the cervix, or the lateral wall. So to screen for the recurrence, we'll look for vaginal bleeding, hematuria or dysuria, constipation or melena, pelvic and even leg pain, fistulas in the bladder or the bowel, sacral back pain or pain in the sciatic distribution. Of course, you may also have costovertebral angle and flank pain. Thank you for spending your time to actually listen to this very long lecture on cervical cancer. I hope it really opened your mind. If it did, consider dropping a subscription plan to this. But before I actually go this, I think there is a warm-up question that we should have answered. Okay, here's the warm-up question. So cervical cancer is the 3rd most common cancer in women. So this is not true. The incidence is increasing. This is true. The rate of deaths from cervical cancer has remained steady over the years. No, this is false. It has definitely changed. Then types 14 and 18 are the most associated with cervical cancer. No, it's 16 and 18. Then of course cervical cancer is associated with previous infection with herpes simplex. No, it's usually associated with HPV. So like I said, if you enjoyed this video, subscribe, tell a friend to jump on the bandwagon, and also subscribe to the channel, like the videos, drop a comment to show some support. My name is Dr. Moses Kazevu. Until next time, bye bye.